This is part 4 of GI disorders and bowel elimination problems, and we're talking now about hypertrophic pyloric stenosis. So this is the pyloric sphincter, which is at the base of the stomach, overgrows. So the baby eats and eats and eats, fills up the stomach, but it can't get out of the stomach. So then the baby projectile vomits it out and eats well, acts hungry, but very quickly gets dehydrated. This typically happens about 6 weeks of life, so you can't go long getting nothing in at that age without getting dehydrated and losing weight. So the treatment is surgery. They go in laparoscopically and snip that pyloric sphincter so that the formula or breast milk in the stomach can move on through. Once the surgery is done, we start feeding these kids pretty quickly. If they do well, we increase their feedings and they go home quite quickly afterwards. They do come in very dehydrated, which also often means their electrolytes are out of balance. But once we get them eating, they're good. So here's a picture, right? Here's our stomach coming down through the esophagus into the stomach, can't get out. And the stomach starts contracting, trying to push it through, and instead you get that projectile vomiting. So what they do with the surgery, this is right a cross section looking at that, they just snip that sphincter so you can get a large enough lumen here to go through. Intussusception. This is where one portion of the intestine telescopes into another, and usually this happens at the ileocecal valve, which is where the small and the large intestine meet. So where they come together, the small intestine slips up inside the large intestine, and the problem is it gets in there, it swells, you pinch off the blood supply, you can have quite a problem. Symptoms usually are a lot of abdominal pain, vomiting, and they usually say current jelly stool. So the stool looks like you've poured jelly, and it's kind of a red-black jelly into the diaper. Sometimes these reduce on their own, so it slips back out, and if they pass a normal stool, that's what's happened. We diagnose it with an enema. Barium shows up really nicely on imaging equipment, but you can also do air or water. That goes in and it shows you that telescoped area, but you're pushing through the large intestine, and it will often push the small intestine back out. So it will also reduce it. It will treat it. If it doesn't work, then or it recurs, they sometimes have to go in and laparoscopically they'll go in and pull the two parts out. And here's kind of a picture, right? Here's our large intestine that should be coming all the way down here, and here's the small intestine slid up into it, and as you can see, the problem is it pinches off blood vessels to the tissues. And here's our appendix hanging off where it should be and where it is hanging off the end at that ileocecal valve there. So malrotation and volvulus. This happens because of this malrotation, this abnormal development of the way the intestines go around the mesenteric artery. It happens embryologically, so in utero. And then a volvus is when the intestines twist around that, they compress or pinch off that artery, so you're getting no blood supply to the intestines. Those intestines, as they get ischemic, they can perforate. The germs that are inside the gut now spill out into the peritoneum. Peritoneum should be sterile, right? So now we develop peritonitis. We've got dead tissue of the intestine that didn't get blood supply, so that's necrotic. This can lead to sepsis and death. And you have to take out that dead tissue. That dead intestine will not come back to life, so you've got to take it out. And you hope it wasn't too much. And if it was, now this is a child who ends up with short gut syndrome. Appendicitis, most common abdominal surgery of childhood. With kids, we get a lot more perforated appendix than you do in adults. And we actually prefer the word perforated to ruptured. I'm not sure why I used the wrong word there, because when people picture ruptured, they picture it explodes. But typically what happens, it's that little thing that hangs off the intestine. It gets plugged. It kind of fills up until it pops in one area. You let it pop, let the fecal material and germs that are inside it get out. It closes back up. No food goes through your appendix. It kind of hangs off to the side, right? So the problem is not the appendix perforating. The problem is all those germs inside the gut, inside the appendix, spilled out into the peritoneum. You get life-threatening peritonitis from this. And the reason kids tend to perforate more is they have such vague symptoms. Here's actually a good picture showing this inflamed appendix, and when it kind of pops in one area, lets that fecal and purulent stuff out, it'll close back up. Right? Here's your small intestine coming into your ascending large intestine. And usually we do laparoscopic surgeries, 3 sites rather than an open surgery, but it is in the lower right quadrant, so if you did an open surgery, that's where the incision would be. So this is why kids tend to perforate. They have these vague symptoms, and they complain of stomach aches all the time, and now they're complaining of a stomach ache. And then they start having some vomiting and low-grade fever. Well, you're not going to take your kid to the doctor every time that happens. And then it perforates, and they develop peritonitis with a very high fever, and they look acutely ill, and that's when they come in, unfortunately. So we do an ultrasound or CT scan to look in there. We look at their labs, elevated white blood cells, elevated CRP. If a child has bad pain and suddenly the pain resolves, that can be a sign that it perforated, so that pressure inside the appendix finally released. They feel better for a short time until they develop the peritonitis and get really sick. But if there's the suspicion of an appendicitis and they suddenly feel better, that's a reason to call the doctor immediately, because that's likely they've just perforated. Usually they'll do laparoscopic surgery. At children's, we have a little different protocol than what our book says. At children's, if it is not perforated, we have a swollen, inflamed appendix, they go in and they get it out. If it's already perforated and we have peritonitis, they try and treat the peritonitis with IV antibiotics first. And then, 6 weeks or so down the road, when the child's well, they bring them in and do an outpatient laparoscopic surgery to get that out. And the reason for that, if you do surgery while everything's irritated and inflamed, you get lots of scar tissue problems, and that can lead to lifelong issues. If you get these bands, these strings of scar tissue connecting two things, right? Your intestines should be able to kind of move and push stuff through, and if you've got a string there, it doesn't quite let it move right. So that's why we prefer to not do surgery when everything's all inflamed, if we can help it. Okay, moving on to chronic disorders. We'll start with reflux, which is transferring gastric content up because the lower esophageal sphincter isn't tight enough. It lets things in the stomach move back up. So who gets this? Well, preterm babies, neurologically impaired kids, or if the stomach just stays full too long, so we have delayed gastric emptying. The best way to diagnose this is with a 24-hour pH probe. So you put an NG down that's got a little pH sensor on it right above the esophageal sphincter, and you monitor it to see when acid hits it, because that stomach acid, the stomach content is more acidic. You can do an upper GI series, so put a scope down and look at things, and then do biopsies to see what's going on in there. So management, if the child is growing well and they just spit up a lot, we don't do anything. We tell parents to quit overfeeding them. Things that can help keep them upright after they eat. Don't feed them and lay them down. That would also mean, right, don't prop bottles. Don't have them eating in bed. More frequent, smaller feeds can help. With a child, if there's certain foods that trigger it, avoid those. We'll use those same meds we use with adults, our H2 receptor antagonists, so that you make less acid, so what does come up doesn't irritate. The proton pump inhibitors reduce acid, but they also increase the tone of that sphincter, and they really help in healing if you've got a lot of irritation. And prokinetics, you'll see we use this quite a bit at Valley Children's. Metoclopramide is the one we use. Reglan is its brand name. It speeds up stomach emptying, so their stomach doesn't stay full as long. And if none of that works, they might need surgery. We do a Nissen fundoplication. So this is your stomach, right? Here's your esophagus. Your diaphragm would be right along here. And the stomach, the top of the stomach is called the fundus. So we take this fundus, wrap it around, and stitch it there. So basically we're making an artificial lower esophageal sphincter, or I guess that's an upper gastric sphincter. Constipation and encopresis. Constipation means having large, hard, painful stools. Now, with an infant, especially a breastfed infant, breast milk is so fully absorbed, they often go days without stooling. Some of them stool every time they eat. Some of them go days without stooling. As long as the stools are soft and they're able to pass them, they're not constipated. So it has to do with the consistency. They have to be large, hard, and painful to pass. And they cause fecal incontinence usually. And most of the time this happens with kids after potty training age, where either they're embarrassed to go in at school or a public setting, or it hurt when they went, so they withhold. And because they withhold, the stools get bigger and harder, which makes it painful to go, and it reinforces this. So encopresis actually means we have soiling in the underwear after the age where a child's normally potty trained. And it happens because they withhold the stool. The rectum actually gets all stretched out, and you lose that muscle tone because an impaction is in there, and the soiling is liquid stool going around the impaction, and they really have no control of it. It just comes. So we've got to first get rid of the impaction, and then we've got to prevent them from withholding the stool until the muscles in the rectum have regained their contractility. So here's some common causes of constipation divided up by age. Hirschsprung disease. This is also called aganglionic megacolon because you don't have the ganglions, which is the nerves groups. So you have some intestine with no peristalsis. It doesn't have the nerves to make peristalsis. So you push food through until it hits that place where it can't go, and then it backs up. So that's the megacolon. You get this huge impaction right above where the lack of nerves are at. So this has to be treated surgically. You cannot make that part of the large intestine start working. You just have to take it out. So what we usually do is a temporary ostomy. So they go in, they take out the part of the intestine that doesn't work. The part right above it is so stretched out that we need to let it heal. So they'll do a double barrel ostomy. They bring up what's distal because we're going to reconnect it, and they bring up the proximal part that's all stretched out. Do a temporary colostomy. When everything's healed, they'll go back in and re-anastomose, reconnect them. And here's kind of our picture. It's usually in the large intestine and often towards the end of the large intestine. So nothing can move through here, so it backs up here.